The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/XBQ860. Downloadable slides and practice aids are also available.
Hello, and welcome to our virtual webcast, Understanding Innovation in Multiple Myeloma, New Models for Attacking Disease Across the Clinical Spectrum. During this event, we'll explore how a new wave of science has informed and changed how we treat patients with myeloma across the disease spectrum. I'm Dr. Sagar Lonial, and I'm pleased to welcome my colleagues, Shaji Kumar, Robert Orlowski, and Nina Shah. So today's agenda, How I Think, How I Treat sessions, is really going to focus on 4 different areas, which each of us will spend a few moments presenting some data on. We're going to talk about primary therapy, comparing modern triplets, primary therapy, antibody-based quads, antibody platforms in relapsed refractory myeloma, and targeting BCMA with CAR T cells. So let's go ahead and begin. Dr. Kumar, you want to get us started with primary therapy update on standard triplets.
Thank you, Sagar. So what I would like to talk about today is how the initial treatment of myeloma has evolved in terms of the use of different triplets. So the current NCCN guidelines talk about bortezomib, lenalidomide, dexamethasone as a preferred option for a triplet for the initial therapy of transplant-eligible multiple myeloma patients. There are other regimens such as bortezomib, cyclophosphamide, dexamethasone, as well as bortezomib, thalidomide, dexamethasone that are still in the guidelines based on older data. And patients who are transplant eligible would undergo a single autologous stem cell transplant followed by lenalidomide maintenance, typically with other options including ixazomib as well as bortezomib. Now, when you look at the patients who are not eligible to undergo an autologous stem cell transplant, the combination of bortezomib, lenalidomide, and dexamethasone is one of the preferred options. In addition, there is daratumumab, lenalidomide, dexamethasone, and both these regimens have shown improved progression-free survival, and the combination of bortezomib, lenalidomide, and dexamethasone has also shown improved overall survival in phase 3 trials. In patients who are more frail or ineligible to go to a triplet regimen, those patients can get started on a combination of lenalidomide and low-dose dexamethasone. There are other options as well, and including the combination of daratumumab, bortezomib, melphalan, and prednisone, a quadruplet, which you will be hearing more about later. And in these patients, lenalidomide is often continued as a maintenance option until disease progression, as many of these trials been designed for. So right now, based on the phase 3 trials, we have either a proteasome inhibitor with a immunomodulatory drug and dexamethasone, or a monoclonal antibody like daratumumab with lenalidomide and dexamethasone as 2 of the triplets that are currently used in the clinic. Now, one of the questions that had come up based on the data showing that carfilzomib might be a better proteasome inhibitor was, should we replace the bortezomib in the bortezomib, lenalidomide, dexamethasone with carfilzomib? So in order to answer that question, a phase 3 trial called the Endurance trial was designed and run through the ECOG cooperative group. So patients with newly diagnosed multiple myeloma who did not plan on going to an early autologous stem cell transplant or were considered ineligible for an autologous stem cell transplant, as well as patients with standard risk disease with the inclusion of translocation 414 within that group, were enrolled on this clinical trial. And patients with high-risk characteristics like translocation 414, 14, 16, high LDH, plasma cell leukemia, and so forth were excluded. So patients were randomized to receive induction therapy with either bortezomib, lenalidomide, and dexamethasone given as 3-week cycles for a total of 36 weeks, or carfilzomib, lenalidomide, dexamethasone given as 4-week cycles for a total of 36 weeks. And patients were stratified based on the intent to proceed to an autologous stem cell transplant at the time of disease relapse. This trial was designed to answer a second question, to see what is the ideal duration of maintenance therapy after a triplet injection. So patients, once they completed the injection therapy, were randomized to receive lenalidomide maintenance for indefinitely or for a total of 2 years. Now, the trial results showed that the median progression-free survival was identical for the bortezomib lendex combination as well as the carfilzomib lendex combination at approximately 34 months from the time of randomization. When you look at the patients who are older than 70, the median PFS for the VRD was 37 months compared to 28 months KRD. When you look at the group of patients, again, just censoring these patients based on when they went to a stem cell transplant or alternative therapy, again, we find that the median progression-free survival was comparable between the two groups with 31.7 months for VRD and 32.8 months for KRD. So the primary goal of this trial was to compare the PFS between the two groups and to see if replacing bortezomib with carfilzomib in the triplet regimen would improve the progression-free survival. And the results suggest that there is no improvement in the PFS or no advantage to adding carfilzomib or replacing bortezomib with carfilzomib. So we looked at the additional characteristics from the or results from the trial, and we were able to see that the overall non-hematological toxicity frequency was more in patients getting the carfilzomib combination, particularly grade 3 and higher non-hematological toxicity, as well as overall hematological and non-hematological toxicity were higher with the carfilzomib, lenalidomide, and dexamethasone. When you look at the certain specific adverse events that we have associated with these drugs, on the right-hand side, you can see that the peripheral neuropathy was significantly higher in patients getting bortezomib-based triplet, as is expected from the prior studies, with a grade 3 or higher peripheral neuropathy seen in 8% of these patients. When you look at the cardiac, pulmonary, and renal toxicity, one can see that the frequency of these adverse events was significantly higher in the carfilzomib, lenalidomide, dexamethasone group. And these results are quite similar to what we have seen with other carfilzomib combinations in newly diagnosed myeloma, like the Ikaria trial that compared carfilzomib, melphalan, prednisone to bortezomib, melphalan, and prednisone. So what I take away from the results of the endurance trial in the context of everything else we have learned about these two proteasome inhibitors used in combination is that the currently used combination of bortezomib, lenalidomide, and dexamethasone still remains the standard triplet induction therapy for initial treatment of newly diagnosed myeloma. And particularly as shown in this trial, patients with standard to intermediate risk disease and patients who don't intend to go to an early autologous stem cell transplant. BRD does have the benefit of long track record, and we know that the neurotoxicity, which is the biggest issue, can be significantly reduced by use of subcutaneous administration and once weekly. In the current trial, the endurance trial, we did use twice weekly bortezomib for the first 8 cycles. Now, even though the depth of response appeared to be higher in the carfilzomib, lenalidomide, dexamethasone, that did not translate to an improved progression-free survival, likely related mostly to the increased rates of toxicity that we saw, especially the cardiac, renal, and pulmonary toxicity. The results also suggest that the VRD, given the long-term experience and the results that we saw in the endurance trial, remains a suitable backbone for developing quadruplets, such as the ones that you will be hearing later in this session from Dr. Orlowski. So how do I use the various triplets in the current clinical scenario? So there's some basic principles we can use. I think the PI plus imid and dexamethasone, or the monoclonal antibody like daratumumab, lenalidomide, dexamethasone should be the default initial treatment in all myeloma patients based on some of the results that we have seen from several phase 3 trials at this point. For the patients who are transplant eligible, we have limited data with the combination of daratumumab, lenalidomide, dexamethasone. So certainly I think VRD should remain the one of the standard induction therapy for patients going to a stem cell transplant. again, based on data from trials such as the IFM 2009. For the very old and the frail patients, we can certainly consider starting those patients on lenalidomide dexamethasone and adding the third drug based on tolerance. For patients with high-risk myeloma, a proteasome inhibitor is important. So either using the bortezomib lenalidomide dexamethasone or using the daratumumab bortezomib lenalidomide dexamethasone would be appropriate choice for those patients. And it's important to note that bortezomib should be used once weekly and subcutaneously. And there are a whole host of clinical trials that are ongoing looking at the role of a quadruplet versus triplet, which will likely change how we treat myeloma, particularly newly diagnosed myeloma in the years to come. And you'll be hearing more about that later on today.
Thank you, Shaji. I think we've got a few questions from the audience, but I want to ask my colleagues here a little bit about how this trial has impacted your practice. So Bob, why don't we start with you first, just sort of for a high level, how it has impacted, if it has at all.
Well, I think it shows the importance of doing the randomized studies, because probably all of us would have hoped, for the sake of the patients, that KRD was going to be better than VRD. And to some extent, surprisingly, that turned out not to be the case. I do think that KRD still has a role to play, because if you have, for example, a high-risk patient where you may be able to get a deeper response, although I emphasize may because we have to prove that, that could be of value. And if you're taking somebody to transplant and you're planning on a brief, let's say 4 courses of therapy, 4 cycles of treatment, it could still be that KRD would give you a more rapid response, in which case it could still be considered. And I think although the toxicity argument is a powerful one, it's also important to know about reversibility. Neuropathy often is less reversible than are some of the cardiac, pulmonary, and renal toxicities that we see with carfilzomib. And it would be exciting to see that kind of analysis of the ECOG data.
Thanks, Bob. Nina?
Yeah, I agree with Bob. I think there are so many variables when we talk about myeloma therapy, triplet, doublet, the different drugs, and then the element of transplant. And so it's hard to know, if you think a patient is transplant eligible, how you would interpret this data to choose an induction regimen. I still think that VRD can be considered the standard of care, but I wouldn't, if I was taking a patient to transplant, give them 9 months of therapy, for example. So it's just a little bit hard to fit that into maybe what I would do for a transplant eligible patient. But I do think it's reassuring to know that if you choose either, you're not going wrong, and you can think about the patient and what he or she would best tolerate to make your decision. So I guess that is a really good part of what we can take away from these randomized trials.
Yeah, no, Nina, you bring up a good point. And I know Shaji, I think, has done this analysis, response rate at cycle 4. And at least I believe my recollection was they were identical at cycle 4 as well. Is that right?
That is right. There was a slight increase in the VGPR rate with the KRD versus VRD, but the cycle 4, or actually it's more like the 16-week response was fairly comparable when you compare the.
Yeah. So let me ask one more question to the group, because what this really, the median PFS of roughly 31 months, to me, really speaks to the question about the value of additive benefit of transplant early on in the disease course. So, between the IFM study, where the median PFS was 48 months or longer, with limited duration maintenance, our recent data for standard risk saying the median PFS is somewhere around 80 months. 31 for a young fit patient is really very short. And I think this to me reinforces the importance of transplant in a younger patient population.
I agree.
I think that's a good point, and we're not yet at the juncture where I think we can get rid of transplant from the algorithm for myeloma.
Yeah, I agree with that.
I was going to say, Nina, I know you want to say something about that.
Yeah, I love transplant. But I do think this allows us to consider what benefit transplant can give. And it's a different mechanism of action of treating the disease. And myeloma is a disease that likes to be hit by different mechanisms. So I think that makes sense that transplant adds something. And it also kind of gives a break. It can be hard to get 9 months of therapy with the same regimen. So that does afford it that opportunity.
It
Yeah.
also allows us to create a platform to improve the outcomes, right, with what you do with transplant and post-transplant. And I think one of the key messages, I think, is that there's only so much you can gain by tweaking one drug, different drugs within the same class. And I think it also highlights the importance. Do we either we bring in a new class or add a new class to this whole backbone to kind of improve outcomes?
Yeah, no, I think you're right. And that's a great segue to Bob's presentation, where he's going to talk us through antibody-based quads and really, I think, try and begin to open the conversation of, is 4 better than 3, since we know 3 and 3 seem to be somewhat similar, at least in your trial. Bob?
Well, thanks for the introduction, Sagar. And of course, this gets back to the tenets that we learned when we were still training as fellows, which is that if a little bit of chemotherapy is good, more has to be better. And what you'll see from this presentation about quadruplets is that the answer is yes, and that the answer may be no in some cases. Triplets, as you saw from Shaji, are really the standard of care for both transplant eligible and for ineligible patients if they're robust enough to get a triplet. But with the advent of new drugs like antibodies, which really don't add a lot of toxicity, it is possible in many patients to consider quadruplets. And one of the first studies which has given us mature data that described that is the Cassiopeia Trial. And this was a predominantly European study where the standard of care was bortezomib, thalidomide, and dexamethasone. And the experimental arm was daratumumab with VTD. And then patients could go on to transplant. Then they got consolidation after transplant with either Dara VTD or VTD, depending on what they had as induction. And then later on, there was a second randomization with Dara versus observation. We know from the progression-free survival data that we have seen so far that the Dara VTD arm has shown an improved outcome. And you can see on this slide in terms of proportions of patients surviving without progression that you have a substantial difference between the two arms. And this is now PFS from the first randomization. It's about a 53% reduction in the risk of progression. And this kind of 50, 60% improvement is a common number that we see in many of the daratumumab containing phase 3 trials. And although the median overall survival was not reached in either arm, we would hopefully expect to see that there would be a difference ultimately, because so far the PFS data look quite good. Now, you've seen already that VRD is the standard of care in the US. So the Griffin study really addresses a regimen that probably would be used more frequently here. And the Griffin trial, which was led by Pete Voorhees, was a phase 2 randomized study looking at VRD versus Dara VRD. Once again, patients could go on to stem cell transplant and then consolidation and maintenance afterwards. And on the slide, what you'll see are the response rates which were greater for DVRD at all of the time points than was the case for a VRD. In particular, you can look at the purple portions of the bar graphs. And first of all, what this shows you is that the longer you treat, the better is the outcome because the CR rates go up. This is true in both arms, but the DVRD people always have a higher CR rate than is the case with VRD. And there also was a higher stringent complete response rate as well as MRD negative rate. Another quadruplet, which has suggested that 4 may be better than 3, came from the Alcyone study. And this was for patients who were transplant ineligible. And VMP, or bortezomib, melphalan, and prednisone, was the standard. And the experimental arm added daratumumab to that. I'm sure you've heard before that there was a better progression-free survival. And here on the slide, what you see is the overall survival with a nice separation of the curves, really starting out at about 2 years, that shows you that the DARA VMP people are doing better. And that really is encouraging because, again, these are people who would not be going on to stem cell transplant. And so daratumumab being given early in this group should be quite exciting. Other than DARA, which of course is an anti-CD38 antibody, there's a very recently approved anti-CD38 called Esotuxumab, and you can use that in combination with POM and DEX for relapsed or refractory myeloma. ESA binds a different portion of CD38, and there are some different mechanistic aspects of its activity than DARA. It also may have, at least in my experience, fewer infusion reactions, although probably once everybody switches DARA to sub-Q, that will be less of an issue. But here in this particular study that you're looking at on the slide, the investigators looked at adding esotuximab to KRD, and you can see the overall response rate was 50% of patients achieving a complete remission, 90% of patients achieving a very good partial remission, and 100% of patients achieving a partial remission or better. Actually, there were only a couple of PRs. Most of them were VGPR or better. I'm sure you recall that VGPR is a 90% improvement in disease burden or more. And MRD assessments showed that roughly 2/3 of patients that were evaluated were actually MRD negative. So it may be interesting to look at this combination as well, and particularly perhaps in high-risk patients. Speaking of high risk, one of the studies that was presented at the recent virtual ASCO meeting was the Swog high-risk study. And the approach that we took here was to use VRD as induction and maintenance, which really drafts off of the data that Sagar and his group have been able to nicely put together. And then in the experimental arm, Esotuxumab was added both to induction as well as to maintenance. And this was a smaller study. It was a phase 2 randomized trial. The reason it was smaller is because high-risk patients, of course, are less frequent among the population. Depending on how you define it, you're talking about maybe 15 or 20% of patients. And we also were hoping essentially to hit a home run, even though spring training hasn't yet started. But we were hoping that we would make a big difference through the addition of an antibody. And if you're looking for a big difference, then you don't need as many patients. Unfortunately, what we found is that the addition of elotuximab, as you can see from the progression-free survival curves, did not change the outcome, and the response rates and complete response rates were not different between the two groups as well. So it shows you that in some cases, 4 will be better than 3, but not in all cases, and again highlights the importance of getting the clinical trials done. So my take-home messages about whether a quadruplet should be used versus a triplet: we certainly have a lot of data now that make it very encouraging to suspect that quadruplets will be well tolerated and potentially more effective, especially the anti-CD38 antibodies, although unfortunately with ELO and SLAM-F7 as a target, that doesn't seem to be the case. And it'll be interesting to look at what happens when we start adding the BCMA targeted therapies. Early deepening of responses may translate to better long-term outcomes, although we do need additional data for high-risk patients. I do think that quadruplets would be great, again, for the people getting, say, 4 cycles or 5 cycles before transplant, and you want to really mash the disease down as much as possible. And in the non-transplant setting, we need some more follow-up, but what we have right now is promising, and really trying to use the best drugs earlier when they're going to have their greatest effect, I think will be of value, especially since adding an antibody typically does not result in a major downside in terms of toxicity. So overall, how I think and how I treat, I still use triplets as the standard of care, but frankly, I have a low threshold for adding DARA if I'm not getting as robust a response from my triplet as I think that we should have. And soon there should be data about Esotuxumab with VRD upfront as well. Again, this could be helpful as a pre-transplant induction. And it's also possible that we could use the strategy that I mentioned, which is adding the antibody as a 4th drug if the 3 drugs alone are not doing as well. For older and frail patients, I think quadruplets are going to be difficult to get in, but it's still possible that if we, for example, in the future could give 2 antibodies with an IMiD and a steroid, that perhaps the added toxicity would be minimal and the benefit could be substantial. For high-risk patients, I think KRD is still a possibility, and adding an anti-CD38 is supported. There was a meta-analysis at ASCO, not the same as a randomized trial, but the best that we have so far, and it did show that adding DARA in a number of upfront and relapsed refractory studies did have a benefit for high-risk patients, although they still did not do as well as the standard risk patients. And other drugs certainly look promising, like the Bcma targeted agents. Thanks very much.
And so let me ask all of you, high risk, what are each of your institutional approaches to high risk myeloma at diagnosis right now? Why don't we start with Shaji?
Sure. Now, I just want to point out one interesting finding, right? I think it kind of validates what you have reported. If you look between the Endurance and the Swog trial, it's a contemporaneous trials, high risk in one, standard risk in the others, and they have exactly the same median PFS of 34 months. And what was different between the 2 trials was they were on VRD maintenance in the Swog trial compared to just lenalidomide maintenance for the Endurance. So I think in a way it validates the importance of having that the triplet maintenance, or at least the PI plus IMiD maintenance. So I think in our own setting, what we have been doing is, again, trying to get the deeper response, as Bob pointed out before, in these high-risk patients. And so I think increasingly we are now starting to switch towards maybe a DVRD approach for the high-risk patients, but definitely using the minimum of that VRD triplet continued with maintenance of bortezomib and lenalidomide until disease progression.
Nina?
Yeah, I think the trials that are presented here illustrate what is sort of lacking in a lot of our myeloma data, which is that we don't have prospective trials on high risk, except for the Swog now. And we need to do more of those. And a lot of what we're doing, we're kind of extrapolating from analyses. And I'm actually really happy that the daratumumab analysis was presented. At our institution, if someone comes in with high risk, we, up until at least now, have been giving KRD, going to transplant, then giving consolidation KRD for several years. A lot of the patients actually have gotten BRD in the community, then come to us. And for those patients, we follow, Sagar, your guidelines of several years of BRD consolidation / maintenance afterwards. But I agree with Shaji that lenalidomide is not enough. And there has to be some PI to IMiD combination after transplant. And so getting aggressive on this therapy is important because these patients are really hard to get into deep responses.
Bob, what are you doing in Houston?
Well, on the high-risk front, we actually have a dedicated effort, which is part of our Moonshot program in myeloma, where we're adding, on top of transplant, we're adding cellular therapy in the form of cord blood-derived natural killer cells. This is actually something that Nina started before she left for UCSF. And she published some nice papers showing that there appears to be an improvement in the MRD negativity rate, and there is some evidence for improvement in progression-free survival. And Nina's colleagues now who stayed at MD Anderson are looking at translating these studies into a randomized trial through the BMT-CTN. So I think that'll be really exciting because there is still, as everybody has mentioned, an unmet medical need for these high-risk patients.
Yeah, no, I think that's a really innovative and interesting idea, Bob. So at our center, for the standard risk, DARA-RVD has become our sort of go-to in the absence of a clinical trial. And then for the high risk, we're using KRD. And I want to touch on 2 points that you made, Bob, and again, maybe get some feedback from the panel here. So you mentioned the meta-analysis, and one of the things that I'm curious about in that meta-analysis is, in my view, it's very clear that high risk in relapsed myeloma is very different from high risk in newly diagnosed myeloma. So I think pooling those results together sort of gives you a skewed view on what the impact of DARA is in the high risk subset. And so when you take it one step further and remember back to Cassiopeia, the original manuscript on Cassiopeia, there was no benefit for the high risk people. And so the way I interpret the change in Cassiopeia now is that you already lost those really high risk early on in that first analysis. There was no benefit for them. And the people that have now moved the pendulum the other way in Cassiopeia are the less high risk people. And so I'm personally not convinced of the benefit of an antibody in high risk. So I'm going to throw that out there as a provocative question.
And the same is true for the Maya trial. Originally, the high-risk data did not turn out, the subgroup analysis was not in favor of DARA, but then for longer-term follow-up, now the hazard ratio has started to move towards DARA. So a similar thing has happened.
And I think this brings up the point that not all high-risk patients are equally high risk, as you're mentioning, Sagar. We have this category of ultra-high risk where people have 4 or more copies of 1q21, or if they have biallelic deletion of 17p, or monoallelic deletion with mutation of p53 on the other allele. And unfortunately, that information has not yet percolated to the level of the clinical trials, because I think if we stratified in those studies based on ultra high risk and high risk, we would at least get a little bit of a fairer estimate. But still, any improvement, even in, if you want to call them moderately high risk as opposed to highly high risk, any improvement in that population is a positive step forward.
Yeah, no, I think it's a really interesting discussion, and our group at least had a knockdown drag out about whether or not to add DARA for the high risk subset in our group approach. And for now, at least as of 4 months ago, we didn't, but I expect there'll be another fight this summer to discuss it a little bit more.
It's also important, I know I agree with Sagar in terms of the meta-analysis not necessarily changing the perception of, the DARA being anything additional for the high risk. But I think the concept is, us replacing a PI with DARA, definitely no for the high risk. The question is whether adding that fourth drug to the triplet by virtue of the depth of response, will it do anything to the high risk?
Yeah, no, I think those are reasonable approaches. All right, so let's shift gears a little bit to relapsed and refractory, and I'm going to talk a little bit about how I treat with established and emerging agents. So let's talk a little bit about CD38 platforms in relapsed and refractory myeloma. So what we saw recently was the phase 3 Columba trial, the non-inferiority comparison of sub-Q versus IV daratumumab in relapsed and refractory myeloma. And I think, as you can see very nicely here, there really was no significant difference in overall response rate. In fact, perhaps slightly better for the sub-Q. If you look at adverse events, the infusion reaction piece actually may have been slightly lower with the sub-Q as well. And more importantly, the time that the patient spends in the chair was actually much shorter with the sub-Q than with the IV, even using the 90-minute infusion approach that Craig Hoffmeister published a couple of years ago. So I think this certainly is an important step forward, and I think is a convenience issue, because many patients who have to travel, the idea of spending 2, 4, 6 hours in the clinic really does become a significant hardship, particularly now where we're trying to minimize time people spend in the infusion centers as a part of the sort of COVID risk mitigation approach. So the next trial really to talk about was Candor. This was a trial presented recently as well that looked at carfilzomib dex versus carfilzomib dex and daratumumab. So again, asking a 3 versus 2 question here. Median follow-up was similar between the two, but significantly longer progression-free survival, overall response rate, and MRD negativity favoring the group that received DARA in combination with carfilzomib and dex. And one of the things that I actually like about this trial more than anything else was actually the fact that this was carfilzomib at the 56 twice a week, which to me, I think is the most effective dose of carfilzomib. It's clearly, at least in my experience, and again, we can talk about this during Q&A, it's probably much better than bortezomib at the 56, using that 56 twice a week. So it's the maximum dose. And I think that that benefit that patients get with the ability to add DARA really makes this a very powerful combination in the relapse setting. I think the other regimen for us to talk a little bit about is the Ikaria trial, which was an Esotuxumab doublet in relapsed refractory multiple myeloma. So this was Pom-Dex as the doublet versus Isa-Pom-Dex as a triplet. And what you can see here again from the progression-free survival curves is almost a doubling of PFS with the addition of Isa to pomalidomide and dexamethasone. Now, this is a slightly different set of apples, if you will, than the previous trial that I showed you, in the sense that because these patients were POM eligible and a significant fraction of these patients were enrolled in Europe, this was an average of 2 or more prior lines of therapy, as opposed to Candor, which took sort of first relapse, second relapse in it overall. But I think that many of us in the US have patients that are progressing on lenalidomide maintenance. And so looking at POM-based salvage therapies really becomes one of the 2 or 3 options that we need to have available from phase 3 trials. And this is actually the only phase 3 trial at this time point looking at Pom-Dex plus an anti-CD38 monoclonal antibody demonstrating benefit over pomalidomide and dexamethasone alone. And I think an important point that many of us have experienced using anti-CD38 antibodies in aggregate is the idea that patients get a very brisk response in terms of renal recovery. And this is nicely shown in the Esotuxumab Pom-Dex trial, where clearly there was a significant improvement in renal function and a much higher rate of complete renal response with the addition of Esotuxumab to pomalidomide and dexamethasone in this group. If you begin to look at treatment emergent events here, what I think, again, you see is that there's not really a significant difference with the exception of infusion reactions, which, again, I think we are anticipating and used to dealing with in any monoclonal antibody-based approach in oncology. And so, again, the incidence of grade 3, grade 4 infusion reactions was very low, with most patients only having a reaction with that first dose, and predominantly this was grade 1, grade 2. So I think, again, in terms of take-home messages and summaries, I think in my mind, the use of antibodies in the first relapse setting really has become the dominant approach for all of us. And the question is, what's the partner? What are you going to partner with an antibody in the context of first relapse? Is it going to be an IMiD, such as pomalidomide? Is it going to be a proteasome inhibitor, such as carfilzomib, as we saw here in the Candor trial? Are you going to go back and use something like bortezomib? I think that's something the group we can talk about a little bit more, but it's nice to have those options of using POM or a PI like carfilzomib-based approaches in the salvage setting, and now having phase 3 data to partner them with anti-CD38 antibodies at this time. I think that's a sort of a great segue again for the group to think through this a little bit. How do you all approach early relapse? We now have what I would argue are 3 backbones. We have an IMiD backbone, we have a PI backbone, and we have a CD38 backbone. How do you decide which to mix and match in that setting of early relapse? So why don't we start with Bob, since we started with Shaji last time?
Well, I think you brought up an important point, which is to understand what the patient has been receiving most recently. And in the second line space, where most people are progressing with lenalidomide on board as a maintenance certainly coming in with a POM-based combo, and this could be POM-DARA, it could be POM-ISA, it could be POM-carfilzomib, makes sense. And also the carfilzomib-DARA combination looks quite good. I think also one can, of course, look at whether it's a slow, sort of indolent progression, where maybe you can tweak things a little bit, maybe modify the len dose or add dex, but with a more aggressive increase, and certainly with clinical symptoms, you want to try to switch out and produce as many new drugs for the patient as possible.
Thanks, Bob. Nina?
Yeah, I agree. I think definitely switching classes is important. Many of us have patients on len maintenance, so we want to switch out of len, even though they may not be quote unquote bortezomib refractory because they got bortezomib before transplant and didn't progress on it. We also still have a tendency to not reuse that drug again. That being said, I think what's interesting is now that daratumumab is available subcutaneous, the combination of dara-pom-dex is actually very easy to administer for people from a lifestyle perspective, because eventually they get on subcutaneous drug once a month and they have an oral agent that they take at home. And so I think a lot of us have been doing that in the second line, even though it's theoretically approved in the third line. And so I'm looking forward to see if Esotuxumab can come up with something similar as well.
All right, Shaji, and then we'll switch to BCMA. You go ahead.
I think it's important to switch classes, and I think both the Candor trial and the Ikaria trial now with data showing that you can add carfilzomib to the monoclonal antibody certainly gives you that option of changing to a completely two new classes of drugs than what they have been refractory to coming off len maintenance. Obviously, that picture will change in the future once daratumumab becomes more commonly used in the upfront setting, and then you are more likely to see patients maybe more refractory to the monoclonal antibody at first relapse, or maybe refractory to both an IMiD and a monoclonal antibody. And then I guess we will go on to the BCMA-based combinations.
Yeah, great. Thank you. This is a nice little break in this section here, because I think we're going to change gears a little bit as we talk about BCMA with antibody drug conjugates. So belantamab mafodotin, or Bellamath, is a new antibody drug conjugate targeting BCMA. And we know that there are multiple different ways to target BCMA. Nina's going to talk to us about CAR T cells in just a few moments, which also are going after BCMA. But what this really brings to the table, I think, is an easily available, potentially off-the-shelf, if you will, approach to targeting BCMA. And we know that in the single-agent DREAM2 study, that patients were seen to have high response rates, about 30 to 35%, with very deep and durable responses in many of those patients. And what I presented at ASCO and EHA this year was actually an update on the DREAM2 duration of response. And now with a median follow-up of 13 months, we see that the DOR, or duration of response, for the 2.5 mg per kg group, which is the dose that's moving forward, was 11 months, which certainly puts it on par with other drugs in this setting of refractory myeloma, such as daratumumab, carfilzomib, or even POM-DEX when they were evaluated in a similarly heavily pretreated group of patients. What really distinguished DREAM2 from those trials, however, is that most patients, if not all, were refractory to DARA coming into this trial, and the median prior lines of therapy was 7 coming into this. So I think belantamab certainly does offer us an exciting and new therapeutic option for many trials going forward. What I think we want to talk about next, though, is some additional data that was presented at ASCO, the DREAM6 study, which combined Bellamath with bortezomib and dexamethasone. And what we saw in the first part of that trial, so only 18 patients, was that the overall response rate was about 78%, and that the frequency of keratopathy, which appears to be the major adverse event, the on-target effect of the toxin, MMAF, was really no different in this trial than we saw in some of the later lines of therapy, suggesting that this was a safe combination to go forward with. And if, again, you look at adverse events of special interest, you do see that there were some areas of keratopathy. But one of the points that I'd like to make about keratopathy, at least from what we know from DREAM2, is that about 40% of all patients who get keratopathy are grade 1, and those were identified by the ophthalmologist only. there were not symptoms associated with that grade 1 keratopathy. So I think these are things that certainly are reasonable approaches for people to think through, and just getting good partnership with your ophthalmologic colleagues, I think, helps you to try and mitigate some of the short-term and long-term approaches of using something like belantamab mafodotin. So I think that, to me, the take-home message on emerging BCMA antibodies is there is clear efficacy in the setting of refractory myeloma. The use of a dose holding or dose delay in conjunction with close ophthalmologic support allows patients who respond to get very long durations of response. And this may be a question for my colleagues to address as well. To me, the DOR in refractory myeloma is an amalgamated endpoint between response rate and safety, because patients that can't stay on the drug because of toxicity, the DOR may end up being shorter, even though the response rates may be similar. And I think the 11-month DOR for patients at the lower dose really does speak to both safety and efficacy of Bellamath. And as I mentioned a moment ago, a real off-the-shelf option for patients who really can't necessarily wait for other treatment options coming forward. So if we want to think about experience with how I think and how I treat in terms of novel antibodies in relapsed refractory myeloma, I think CD38-based treatments can be combined with both PIs and IMiDs. We now have phase 3 data supporting that. For patients who did not receive a 38 antibody as part of initial induction therapy, then using an anti-CD38 antibody in first relapse certainly, to me, makes a lot of sense, and I think should be the backbone to which we add other agents. And as we think about synergy, the IMiD antibody combination, to me, clearly has pretty synergistic activity. The PI anti-CD38 clearly has activity as well, of a triplet versus a doublet. And I think we can all talk through how we might approach that going forward. So let me ask you guys about your experience with Bellamath and some of the responses, as well as ophthalmologic issues that I think are out there in the literature. Bob, do you want to start off?
Well, Bellamath, we were impressed with the efficacy of the drug, and you do need a dedicated ophthalmologist who's going to see the patients at baseline and then during therapy. But even in patients in whom we had to hold therapy, it was rare for us to see any of them progress during that time. And so that was very encouraging. I'd also like to see a combination of Bellamath with a gamma secretase inhibitor, just to see if a higher BCMA density on the myeloma cells could result in an even better response rate.
Really interesting idea, Bob. I like that thought. Nina?
Yeah, so I agree. Bellamath can be a very effective drug. And what I like about the data from ASCO is that it's hard for us sometimes to know if a drug is the right drug for a patient. And this tells you that if you get a response, you should just keep going with that plan, because the duration of response of 11 months is actually very good in this patient population. As you pointed out, they were very heavily pretreated. And it's also important to note that many patients didn't get dosed for several months and they still maintained their response. So adhering to dose holds, those guidelines, having good communication with ophthalmology still allows for patients to yield the maximum benefit from this drug. So I'm looking forward also to combination therapy and maybe moving this more forward. And I think all of us probably need to get our hands wet with trying to manage the drug, as well as talk to our eye health professionals and just get more facile with it to get the maximum benefit out of it.
Okay, Shaji?
Yeah, no, I think you kind of pointed out the fact that even though the response rate might be only 30%, the people who do respond tend to keep the response despite me at times having to hold therapy because of the ocular toxicity. It brings up an important idea in the sense, could there be a biomarker that predicts for response in these patients, especially given you get such durable response in a well-defined fraction. But I think the eye toxicity is something that really needs to be managed, whether it's managed through some kind of more creative scheduling strategy, more upfront therapy, and maybe more staggered to it once you get the response. So certainly a lot more that needs to be learned about it, but I think it validates the target. and the duration of response certainly talks for stability. And one of the interesting thing was it's the same duration of response you see in the CAR T therapy as well, with some of them, and especially when you considering that obviously there's a lot more responders, 70-80% in the CAR T, so the global benefit is certainly more for that modality, but the people who respond really do well in this.
I was going to hit Nina with that point after her talk, but before we get to her, let me ask everybody with just a quick thumbs up, thumbs down. Have you all made the switch to sub-Q, Dara, wholesale, or are there areas where you're still not quite doing it? Or tell me how you all are approaching that. Across the board, Bob?
It's doing it in as many patients as we can.
Yeah.
Of course, with the current COVID restrictions, it's a little bit slower than we would otherwise like, but that's the plan.
Okay, Nina?
Yeah, we're switching over for sure. And we have some trials that are doing it anyway, so it's been nice to use it.
Yep, Shaji?
We're doing the same thing with just a word of caution for the smaller patients when you combine that with drugs like pomalidomide.
Yeah, okay, interesting thought. Yeah, we've tried to switch everybody we can to it as well. All right, so with that, let's transition to Nina to cover BCMA CAR T-cell therapy in relapsed and refractory myeloma.
Thanks so much for letting me talk about one of my favorite topics, which is BCMA CAR T-cell therapy for myeloma. And just by way of background, BCMA stands for B-cell maturation antigen, which is a great target for multiple myeloma because, as you can see in this diagram, it's expressed on the later lines of B-cell lineage going all the way now to the plasma cells. And it's expressed pretty much entirely on this B-cell lineage and not on other cells in the body. So it makes it a very specific target for multiple myeloma, plasma cells in particular. The function of BCMA is really to enhance proliferation of these plasma cells. So it makes sense that targeting it would be good. But it really is the fact that it's a specific target that makes it very ideal for CAR T-cell therapy. With that, I want to talk a little bit about a couple of abstracts that were presented at ASCO. First, I want to talk about the update with the anti-BCMA CAR T-cell ide-cel, which is formerly known as BB2121. This is a BCMA-directed CAR T-cell that we've heard a lot about over the past few years, but finally we got to see the update of the pivotal phase 2 KarMMa study, which many of us participated in. Here, patients with relapsed refractory multiple myeloma and at least 3 prior lines of regimens were eligible. Now, all of these patients had to be exposed to IMiD, proteasome inhibitor, and anti-CD38 antibody. And importantly, they had to be refractory to their last therapy per IMWG criteria. And I point that out because this was a very sick population of patients and actually sicker than their original phase 1 data, which might explain some differences. As you can see from the schema here, it was very similar to other CAR T studies. Patient underwent leukapheresis. Most of them got bridging therapy. And ultimately, after cell manufacture, they got fludarabine and Cytoxan lymphodepleting chemotherapy, and then CAR T cell infusion. So the primary endpoint for this study was overall response rate, hoping to get past a 50% response rate. And they also looked at secondary endpoints as well. They had screened 158 patients and ultimately treated 128 patients, which is what the data is being presented as. They did use different dosing levels. They were kind of trying to figure out what was going on, what was the best dose for this product. So initially started at 150, but quickly moved up to 300 and then 450. And so for the median follow-up for all doses, it's 13.3 months, but a little bit longer for the earlier, lesser doses. So what do we see here? Here's the slide that shows the overall data and also broken down by dose. As you can see on the right-hand side, the overall response rate was 73%, with the complete response rate of 33%. There does seem to be a dose response effect here, where the higher doses, for example, a 450 dose, 450 million flat dose, yielded an overall response rate of 82%, with a complete response rate of 39%. So The median time to response for this, and we've seen this with other BCMA-based therapies, was 1 month. And so you can kind of tell where patients are going to go by 1 month. And it's not shown here, but the overall duration of response for all of the patients was 10.7 months and a PFS of 8.3 months. But the median PFS and duration of response for the 450 dose was higher, 11.3 months. And for those patients who did achieve a CR, the median PFS was 12 months, which suggests that, again, getting to a response makes you do better, and potentially higher doses are better for this therapy. So this was very interesting data, a little different than what we had seen from their phase 1 experience, but probably a little bit sicker of a patient population, and I think warrants a lot of discussion. If you look at the safety from the KARMA study, you can see that nearly all, a very large percentage of patients, 84% of patients had CRS, but the vast majority of it was pretty much grade 1 or 2, pretty manageable. Patients, half of them got steroids, tocilizumab, half of them got tocilizumab, and some got steroids, but it tended to be very low grade CRS, fairly manageable. And it seemed that it was a little bit higher in the higher doses, but again, fairly manageable. So want to move on to another CAR T cell therapy. This is the J&J 4528 product, which was evaluated in the CARTITUDE-1 study. And this data, again, was presented at ASCO this year. Really a highlight or an update of what they had shown at ASH a couple of months earlier. So this CAR T cell therapy is a little bit different than the BB2121. It uses a llama-based heavy chain only binding domain, and the binding domain on the extracellular surface of the CAR T actually binds to 2 different epitopes of BCMA. So a little bit different as far as how it interacts with the myeloma cell. This product had originally been evaluated in China and then taken over by Janssen. And so the point of the study is to really try to see if they can recapitulate the very nice and dramatic results that were seen in the Chinese population. As you can see on the right-hand side, and we knew this from the ASH presentation, there was an overall response rate of 100%, which really is quite remarkable considering that these patients were heavily pretreated, median prior lines of 5 for the whole population. And this was an American population, so this was what we are used to seeing in our CAR T population. The data was subsequently updated this year at ASCO, and you can see that the depth of response is actually also very impressive. 97% of patients achieved at least a VGPR or better. This is their first cohort, 29 patients, so we await the rest of the patients that were enrolled in the phase 2 study, but very promising data so far. And the follow-up is still short, so we don't know exactly what that's going to be, but again, it looks promising. Similar to what we saw before with the safety data, most patients did have CRS. 93% of patients had CRS, but again, it tended to be very low grade, grade 1 or 2. 10% of patients had neurotoxicity, again, fairly low grade, generally pretty manageable. I think what's important about this CRS, it looks to be a little bit different than what we saw in BB2121, where the median time to onset is 7 days versus 1 day with 2121. Again, these are different products, so they may have different kinetics. They also saw a good amount of cytopenias with this product. I think that's sort of table stakes for CAR T cell therapy. Almost every CAR T therapy or any of these sort of T cell mediated therapies do cause cytopenias, and it's not something that we are afraid to deal with, but we should have a low threshold to act upon them and monitor them, because it's an important thing that can happen even for a month or 2 out from the therapy. So I think this data is really important to help us to understand what's coming down the line for CAR T cells. We've waited so long, and how are we going to position this with our other therapies that you've heard of already? So my take homes for this particular therapy, considering the KARMA and CARTITUDE-1 studies, is that CAR T cell therapy is effective, but as I pointed out with the median PFS data for BB2121, it's not curative, and I think we still haven't gotten there yet. It looks like the benefit from BB2121 is going to be at the highest dose, and it's about a year, 11.3 months, which is similar to what we saw in the phase 1 data. And some people can say that's a bad thing, it's only a year, but you have to remember it's a year without any other additional cycles of therapy. So I think that's a point to consider, particularly when you think think about quality of life. We definitely need more follow-up from the J&J 4528, but it really looks promising. I'm excited to see what their PFS is going to be. CRS in either product, 80, 40, 93%. I think you can pretty much guarantee that if you give patient CAR T cell, you should expect that they will probably have CRS. Generally grade 1 to 2, fairly manageable with tocilizumab. Some patients got steroids, but I think also some interesting correlative data that was presented at EHA for the BB2121 product, that patients who did relapse, actually their plasma cells did not have BCMA loss. So this suggests that BCMA loss is not the mechanism of progression or resistance to this therapy, which is kind of different from what we've seen in CD19 data. And it does suggest that maybe retreatment with an alternative BCMA specific therapy might be a possibility. And also, I appreciated the quality of life data that was also presented from Karma EHA, which actually showed that CAR T therapy was associated with improved quality of life. And there is sort of a mandate now that we have to look at quality of life when we think about all of these therapies, because that's sort of the other form of response and success, making sure that patients are still having quality of life. So how I think, how I treat, how am I preparing CAR T to take over a little bit of the space in myeloma? So who should get CAR T cells? This is always a debate. So I think it's going to come down, of course, to the label, patients receiving 3 lines of therapy or more. But about fitness, and it's hard because some people say, well, do they have to get a transplant or be transplant fit in order to get CAR T? And I don't think of it so much of that anymore. I think there are some similarities, but I think to myself, okay, if a patient could handle hypotension and get 3 liters of fluid very rapidly and nothing bad would happen, I think that person could get CAR T therapy, because that's sort of the most severe thing that happens very quickly. And how about institutions? How are we going to prepare? We've had a lot of discussions about this, and I think we're going to have to change or increase our apheresis structure, because we'll have both transplant and in the later lines CAR T, increase our outpatient infusion capacity and a lot more SOPs thereof, so that we can all learn and know how to treat these patients, and know how to triage their fever, know who needs to be admitted, et cetera. And how are we managing toxicities? Well, I think sometimes it's nice to be second at the table so we can learn a lot from our CD19 colleagues. Initially, there was some hesitation to use tocilizumab, but we do use it a lot more liberally, I think, now than we did before. Usually, first line of therapy is tocilizumab, but if CRS persists, you can consider steroids. You can also consider if they have neurotoxicity, and if they start to develop this macrophage activation-like syndrome, MAS-like syndrome, we've been using anakinra. I always say, hashtag no toci shame. There's no evidence that tocilizumab administration is related to an adverse outcome with myeloma patients with CAR T or CD19. So I think it's important to keep the patient safe as much as possible, so we can actually yield some efficacy of the therapy. And with that, I think I'll turn it over to our Q&A.
Thanks, Nina. I think we've got some good questions to deal with. So a question that's come to us is, can you see a situation where patients are progressing on an anti-CD38 based induction with or without a transplant, and that CAR becomes the first salvage approach?
Yeah, so there's a trial to evaluate that. It's being run, actually there are 2 trials to evaluate that, randomizing patients to get CAR T versus, for example, well, in this case, it wouldn't be a daratumumab-based regimen, but an alternative salvage therapy. And I think that that's where CAR T is heading. And one of the good things about that actually could be that maybe earlier, maybe making this therapy available earlier in the patient's course allows for a healthier T cell population. That's sort of hand waving. We don't know that yet, but that's one of the potential advantages.
Yeah, and so now that we are, we saw the data on the ADC, we've seen data on bispecifics and BiTEs and CARs. How are we going to sequence these agents and decide sort of when somebody gets what? And do you think if they get one in one class, they're not going to get anything else that targets BCMA? So Bob, why don't you start us off?
Yeah, it's, I guess, the $64 million question, and we don't yet have enough data in the patients that I've had who have received a BCMA-targeted CAR and gotten a response, but then relapsed, and we've been able to go to the ADC. We've not seen good responses so far. And many of the bispecific trials, unfortunately so far, exclude people who've had prior BCMA targeted therapy. So I think one thing as a field that we do need to develop is to decide which assay, which antibody we're all going to use to measure BCMA, because although some of the studies show that the level of BCMA expression doesn't influence response, I think if you're BCMA negative, I don't see how you would benefit from that therapy. The challenge is we don't know how best to measure that. And I think that would help with sequencing.
That's an interesting thought, I guess. And you may have seen this in the lab. So outside of people exposed to BCMA targeted agents, is there really a big proportion that are truly BCMA negative?
At least in the laboratory, if you look at cell lines, which of course is a long way away from actual primary samples,
right,
there usually is a BCMA low or in some cases negative population. And a couple of people in publications, Eric Smith being one of them, have shown that you can relapse in that setting. So there definitely is some BCMA negative myeloma out there.
Yeah, interesting observation. Shaji, how about you? How do you think we're going to put all these together?
Yeah, it's going to be a challenge. And I think clearly we need data in terms of sequencing. Is there any platform that precludes one of the other platforms from being used, being the most important question. But I think in terms of the adaptation in the clinic, it's going to be a lot dependent on the availability and the ease of administration. And I think, by default, the cellular therapies are going to be limited to some of the larger institutions. And once the ADC comes out into practice, assuming that, again, we get all those T's crossed and I's dotted with respect to toxicity management, I think that will be available in the community setting, and the oncologists are very comfortable using the ADCs based on their prior experiences. So I think that will end up being used a lot more than the cellular therapy in the near future. And then automatically, I think we'll find the data as to can we still use the T-cell engagers or the CAR T-cells to salvage those patients.
Yeah, it's interesting. I wonder whether you could use one BCMA targeted agent as sort of your bridging therapy, if you will, and then predict for better responses to CAR T cells if you have less tumor burden than most of our patients do going into these trials. So you wonder whether that the biomarker could be, do you respond to an ADC? Do you respond to a BiTE or a bispecific? And then use that as justification for coming in with a CAR afterwards and see whether that prolongs PFS. It's one way to think about bridging.
It's a difficult question. The question is, do you get rid of all the most sensitive BCMA targetable cells, and you don't have enough of those antigens to be available for the immunotherapy? Who knows?
Yeah.
I think the other thing that would help us a lot, probably the ADC will be an approach to give to the patients who, of course, are not going to be well enough to get either a bispecific or a CAR T cell. But for the bispecifics, it would also be probably helpful to understand the immune microenvironment. I would assume that if you have just flat out exhausted T cells, that probably a bispecific will not be the right way to go. The question is how to define that and to validate that algorithm. And then for patients like that, either an ADC or perhaps a CAR T cell, but potentially using allogeneic T cells would be the way to go.
Yeah, I think that's a really important point that you make, Bob, because I guess for better, that each of these BCMA modalities works in a different way for its effector mechanism. And the T cells that we give back to patients for CAR T cells, even if they're autologous, are essentially foreign T cells. And my guess is they get rejected pretty soon after they go in, and they just do their business. And the same, of course, will happen if it's allogeneic T cells. So you could imagine that you use up sort of your reservoir of T cells for the BiTE and then go for a CAR, or vice versa. And you're relying on different T cell populations. And because of this, I really think that the long-term data, we don't have very much at all for the bispecifics, is going to be critical for us for our understanding of T cell exhaustion and how it allows, or, how it affects the response and duration of response to the bispecifics.
Well, thank you. The good news, I guess, for us is there's still lots of work to do. And I think we'll spend the next few years trying to put all this together. This has been really a great discussion. Thank you, each of you, for really giving us your sort of how I think, how I treat approach at your individual institutions, and really providing these important updates for people from ASCO and EHA.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/XBQ860. This educational activity is supported by educational grants from GlaxoSmithKline, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, and Sanofi US. This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education.